Welcome to the Deep Dive. We're here to unpack complex information, find those key insights that really matter.
And today we're getting into something critical, especially if you're an endocrinologist or diabetologist working in India.
Absolutely. We're diving into a major pan-India study on monogenic diabetes.
That's right. The paper by Mohan and colleagues, it's a huge piece of work, pulling data from, 65 centers across the country?
65, yeah. And our goal here today is pretty straightforward. Cut through the academic density.
Get to the practical stuff.
Exactly. Pull out the actionable information that you can actually use in your clinic. Things to help you spot, diagnose, and crucially, treat monogenic diabetes better in your patients.
Right, within the Indian context specifically.
So let's start with the big problem this study really highlights, misdiagnosis. It seemed to be a major hurdle.
It really is. Monogenic diabetes, it's this less common, non-autoimmune type, single gene mutation causing early onset hyperglycemia.
Sounds specific, but the trouble is,
it often looks a lot like type 1 or type 2 diabetes, especially early on. And T1 and T2 are just, they're far more common, far more familiar.
So physicians might just default to the more common diagnosis.
Understandably, yes. But here's where it gets really quite concerning from a patient care standpoint.
The delay.
The study points out that the correct diagnosis of monogenic diabetes often came, get this, 5 to 15 years after the diabetes first showed up.
5 to 15 years, wow.
Think about that. For potentially over a decade, someone could be on the wrong treatment path.
Suboptimal control, maybe unnecessary drugs.
Exactly. Years of maybe struggling with insulin when a simple pill could have worked wonders. Or missing other signs if it's a syndromic form. It just hammers home how vital getting that diagnosis right and early really is.
Which brings us to why this pan-India study is so important. It's really the first big systematic look across India using set clinical criteria and, crucially, genetic testing.
Right. They were systematic. They looked at 774 people across all those centers, and they had clear criteria for who to screen.
What were the key ones?
Age at diagnosis 30 or under, BMI also 30 or under, a family history, so at least one parent with diabetes, and no history of ketonuria.
Pretty standard flags for suspecting something other than classic T2 in a younger person.
Yes, and they also mentioned optional things clinicians often look for, like preserved C-peptide levels or negative autoantibodies, trying to rule out type 1.
Okay, so they applied these criteria, screened these 774 individuals. What did the genetic testing actually find?
So overall, they confirmed a monogenic diabetes mutation in 15.5% of those they tested. That's 120 people out of the 774 who looked suspicious based on clinical grounds.
15.5%. That's not insignificant.
Not at all. And it suggests that even with those criteria, picking the right people to test is still tricky. The paper actually touches on this, suggesting that maybe criteria developed in, say, European populations don't perfectly fit the Indian scene, where you have so much youth-onset type 2 diabetes muddying the waters.
So the signal-to-noise ratio is tough. Needs refinement, maybe?
Could be. It points towards needing better risk tools, perhaps specific to this population.
Okay, so of that 15.5%, what were the types? Was it mostly MODY?
Predominantly, yes. MODY, maturity onset diabetes of the young, made up the bulk of it. That was 89 individuals, which is about 11.5% of the total group they screened.
So MODY is the main player.
It is, but not the only one. They also found 31 cases of syndromic monogenic diabetes, things like Wolfram syndrome, MIDD, that's maternally inherited diabetes and deafness, and H syndrome too.
Right, reminding us it's not just about glucose control. It can be part of a bigger picture.
Absolutely. Now, if we drill down into the MODY cases, which were the most common, the study gives us really valuable data on the subtypes prevalent in India.
That's key for treatment decisions later.
Exactly. HNF1A, MODY, or MODY3, was the most frequent. It accounted for almost a third, 32.5% of all the confirmed monogenic cases.
Okay, HNF1A is number one. What else was common?
Next up was HNF4A, MODY, at about 16.7%. Then HNF1B, MODY5 at 13.3%, and ABCC8, MODY12, showed up in about 6.7% of cases.
Interesting. And what about GCK MODY, glucokinase? That's often highlighted elsewhere.
It is, but it was actually found at a lower frequency here, only 3.3% of the confirmed cases. That's a really useful piece of population-specific information.
Definitely helps guide testing strategies, knowing the local odds, so to speak.
Precisely. The study also compared the clinical features of those who tested positive versus negative, which is insightful.
What differences stood out?
Well, those with confirmed monogenic diabetes were more likely to be female, about 58% versus 44% in the negative group.
Okay. Anything else?
They were also leaner, lower BMI, which fits with the general picture of MODY versus, say, typical type 2. And their age at diagnosis was slightly younger, on average 17 versus about 20 in the negative group.
Slightly younger onset.
But you mentioned the delay earlier.
Yes, and here's that point again, starkly. Despite the younger onset age, the group with confirmed monogenic diabetes had actually had diabetes for longer when they were studied average duration 7.1 years versus 6.0 years.
So that gap, that diagnostic delay, is right there in the numbers.
It really is. It just reinforces how long people can be living with it before getting the right label and potentially the right management.
And family history, that's usually a big clue for MODY, right?
It is, and the study confirmed it's important. Overall, family history was there in about 90% of the MODY positive group.
So very common.
Very common, but interestingly not universal. For HNF1B cases, it was much lower, only 45%. And while a 3-generation history, that classic pattern was seen in 60% of HNF1A and ABCC8, that still leaves 40% without it.
So a strong family history is a major pointer, but you can't rule out MODY just because it's absent, especially for certain types.
Exactly right. Lack of family history doesn't close the door. Okay, let's shift gears a bit. What does all this data mean for you, the clinician, on a practical level?
Well, I think the first big takeaway is that identifying these patients based on clinical signs alone, even carefully chosen ones, is still challenging in the Indian context.
Because of the high background rate of young onset P2D we mentioned?
Precisely. The overlap makes it hard. The paper itself suggests, as we noted, that the standard criteria might need tweaking or perhaps better prediction tools developed specifically for the Indian population.
And they mentioned C-peptide.
Yes, they referenced other work suggesting that biochemical markers like C-peptide levels can be really helpful discriminators here, even if autoantibodies are negative. That's something practical you can use right now.
Okay, so refining the clinical suspicion is one part. But the really big impact comes after the diagnosis, doesn't it?
Absolutely. The most critical piece, I think, the part with the biggest potential to change patient outcomes, is that the genetic diagnosis allows for precision treatment.
Tailoring the therapy to the specific gene.
Exactly. And this study's findings on prevalence directly tell you where the biggest impact lies. Remember, HNF1A and HNF4A were the most common.
Right, together making up almost half the confirmed cases.
Well, diabetes caused by mutations in these specific genes responds incredibly well to low-dose sulfonylurias.
Exceptionally well, you have in here.
Yes, they are exquisitely sensitive. It's because the mutation affects pathways upstream of the KATP channel, which is where SUs act to stimulate insulin release. So SUs effectively bypass the problem.
And crucially,
these patients often don't respond well to metformin. And while insulin works, it's often not necessary and certainly less convenient than a simple, inexpensive SU tablet.
and the study found people on insulin who shouldn't have been.
That's the clincher. They found that 30%, 3 out of 10 of the HNF1A and HNF4A patients identified in the study were actually on insulin therapy when they were referred.
30%.
Just pause on that. These are patients who could likely achieve good, maybe even better, control on a cheap once-a-day pill, but instead they're managing insulin injections, schedules, blood sugar swings, potentially related to incorrect therapy.
The impact of switching them is huge.
It's potentially life-changing for them. Fewer injections, lower cost, often better control, better quality of life. It's a massive win, and it applies to a significant chunk of the monogenic cases you might find.
A really powerful argument for seeking that genetic diagnosis in the right patients. What about the other types? GCK, MODY.
GCK. Although less common in this study, getting that diagnosis is vital for a different reason. GCK causes mild, stable hyperglycemia. It rarely causes complications.
So the treatment is?
Often, no treatment is needed at all. The genetic diagnosis here prevents unnecessary worry, unnecessary medication, unnecessary monitoring sometimes. It's about demedicalizing a benign condition.
Also very valuable. And HNF1B, the third most common.
HNF1B is a different beast. It often comes with kidney problems or other issues. The diabetes itself can be more severe, and insulin is frequently required. So the diagnosis isn't about switching to SUs, but it's critical for anticipating and managing the renal side and other potential complications.
Got it. And the syndromic forms, like Wolfram, you mentioned diabetes can be the first
Oh,
sign.
yes, that's a key clinical pearl. While we think of syndromes having multiple features, hearing loss, vision problems, etc., the diabetes might show up years before anything else is obvious.
So you need to think broader than just MODY.
Definitely. The study noted parental consanguinity was higher in the syndromic group, about 38%, which can be a clue, especially in India. But even without obvious features or consanguinity, if you're testing for monogenic diabetes,
You should probably use a panel that includes those key syndromic genes.
I think that's advisable, yes. Using a targeted NGS panel that covers the common MODY genes and important syndromic genes gives you the best chance of catching these cases early, even if they only present with diabetes initially. It allows for proactive surveillance for the other features.
And finally, the diagnosis isn't just for the patient sitting in front of you.
Critically important point, it's about the family too. A confirmed genetic diagnosis is the cornerstone of accurate genetic counseling.
Allowing for testing of relatives.
Exactly. Screening family members who might carry the same mutation lets you identify a diabetes risk or risk of syndromic features much earlier. You can then offer proactive monitoring, early intervention, maybe even lifestyle changes that could delay onset. It improves outcomes for the whole family.
So let's try and wrap this up. What's the big picture message from this Pan-India study for our listeners?
I think it provides really valuable specific data for the Indian context. It confirms monogenic diabetes is present, gives a sense of the subtype frequencies, but maybe most importantly, it starkly highlights that we're still missing cases or diagnosing them far too late.
Right. So for you, the expert clinician seeing younger patients with diabetes, especially if they're lean, have that family history, maybe preserve C-peptide.
You need to keep monogenic diabetes high on your suspicion list. And pursuing that targeted genetic testing isn't just, an academic exercise.
It's about the treatment implications.
It's absolutely about enabling precision treatment, particularly that potential switch to SUs for HNF1A and HNF4A, which is so impactful. And it's about managing associated features and other types and extending care to the family.
Better outcomes, better quality of life, potentially.
Definitely, which really brings us back to that challenge the study surfaced. If the current clinical criteria aren't perfect filters in this population.
How do we get better at selecting patients for testing?
Exactly. How can we best use the tools we do have, like C-peptide, maybe develop better risk scores? And critically, how do we improve access to comprehensive, affordable genetic testing?
Because the ultimate goal, really, is to make sure every single patient who has monogenic diabetes gets that correct diagnosis and gets the most effective, tailored treatment as early as possible.
That's the key challenge moving forward, building on these important findings, finding those patients sooner rather than later.